You can see the screen well. You can
Okay.
start, sir. Please.
Okay, thank you. What I hope to do over the next 15 to 20 minutes or so is take you on a journey through imaging of bowel obstruction, which is a common and challenging clinical problem that accounts for about 20% of all acute abdominal surgical conditions. Important to remember that small bowel obstruction is about 5 times commoner than large bowel obstruction. The clinical manifestations are fairly non-specific, and the severity and the time scale at which these physical symptoms they occur depends on whether we are dealing with small or large bowel obstruction. And because of the non-specific nature of the clinical symptomatology, imaging plays a very vital role. The time of making your diagnosis is critical because if we delay the diagnosis, there is a profound increase in morbidity and mortality. Reliance on imaging has steadily increased over the last few decades. The main question that needs to be answered, in addition to the presence and etiology of obstruction, is whether surgical intervention is required or not. And we'll see how imaging can help us in making that diagnosis. In the modalities that are available to us, this is arguably one condition where plain radiographs still continue to play a useful role. A patient who presents to the emergency with the symptomatology of obstructive symptoms is...
Raju, sir, sorry to interrupt you in between. You've stopped sharing screen, so if you can just kindly refresh, and your slides have just gone off.
I have not done anything at my end, actually.
So just let us figure it out as to where is the issue. Just give us a second.
Can you just share your screen, sir, please?
Sir, screen sharing बंद हो गई उनकी.
Sir, somehow the screen sharing has stopped, and probably you need to just do it once again to start it up.
Just end the slideshow. Again, go to the Zoom, share screen, and come back on the slideshow, sir.
How do I exit the...
Escape, press escape button, sir.
Yeah, I've done that. I need to get out of Zoom once?
No, you need to minimize your PowerPoint once and go back to the Zoom.
I have minimized my PowerPoint, but I can still see the screen, my own computer screen.
Yeah, just press escape again, sir.
I've done that.
Okay. Are you able to see Zoom now?
No, I'm not.
It's a Mac or it's a Windows?
It's a PC.
Okay, so at the bottom,
I can see it. I can see it now.
Just go to share screen, sir. Perfect, sir. We can see your screen. Just minimize the Google.
Is it okay now?
Yes, sir. We can see the screen. Thank you so much, sir.
Okay. I apologize for that interruption. So amongst the radiographic modalities that are, the imaging modalities that are available to us for evaluating a patient with bowel obstruction, plain radiographs is what we start with. Sonography plays a very limited role, perhaps only in children and pregnant women, where we don't want to use any radiation. CT is really where the money lies for evaluation of bowel obstruction, and it is the modality of choice because it gives a wealth of information. CT enterography is perhaps used only in the situation of low-grade obstruction. When there is subacute obstruction and we are not able to delineate the site, then we may rely sometimes on CT enterography, and MR really does not play a useful role in this clinical setting. The questions that a radiologist is expected to answer are, is obstruction present? Where is the level, which we do by identifying the transition point? And I'll show you examples of that. Is there a single transition point, or is there a closed loop obstruction? A closed loop obstruction is a very important and ominous condition that needs to be identified by the radiologist, where there is an obstruction at 2 points placed close to each other. What is the likely etiology? And is there any complication like vascular compromise, necrosis, or perforation, which would mandate surgical intervention? And these are very ominous findings, which need to be conveyed to our clinical colleagues as urgently as possible. So amongst the radiographs, we do an abdomen erect, an abdomen supine, and an erect chest radiograph for showing the presence of pneumoperitoneum underneath the dome of diaphragm. If we had the option of doing just one radiograph, then perhaps it is the supine abdominal radiograph, which is the most useful in this clinical context because it helps us to identify dilated loops and show the point of transition where the dilated loops change over to normal or collapsed loops. It helps us to triage the patient workup further. If the patient is severely ill and you cannot make him stand, then you can do a lateral abdominal radiograph. However, radiographs, although they do give us some information, their sensitivity is only moderate and ranges between 40 to 70%. There is a rule of 369. This is the upper limit of caliber. Any small bar loop more than 3 centimeters, large bar loop more than 6, and cecum more than 9 centimeters is considered abnormally dilated. Air fluid levels of more than 2.5 centimeters width, especially if they are at a different level and they produce a step ladder kind of pattern, are significant. We have to differentiate obstructed bowel from paralytic ileus, and we'll talk of that in a little while as well. As I referred to earlier, CT is really the modality of choice, has a high sensitivity and specificity, and provides a global perspective of the entire abdomen. It is not hampered by the presence of bowel gas or body habitus. In today's time, we sit on a console and look at very thin sub-centimeter, sub-millimeter slices and rely a lot on multiplanar reconstructions. Incidentally, we do not use any oral contrast because the bowel is already distended with fluid, and that fluid provides a neutral oral contrast as it is. However, IV contrast is useful unless it's contraindicated because of deranged renal functions. If we are suspecting bowel ischemia, we could couple it with a CT angiography in the same sitting, and we must pay attention to lowering our radiation dose. So once we have a plain radiograph in front of us, we try and distinguish mechanical obstruction from paralytic ileus. How do we do that? In mechanical obstruction, you can always identify a point of transition from dilated to collapsed bowel. Paralytic ileus, on the other hand, is a condition which is characterized by a motility problem. There's no mechanical obstruction. And here there is a commensurate dilatation of both the small and the large bowel, and no transition zone is identifiable. Once you have obstruction, you need to figure out, is this small bowel obstruction or large bowel obstruction? I'll show you that with an example in the next slide. And then most often we would resort to a CT in the present times to try and see the etiology and the presence or absence of vascular compromise, and to decide if the patient can be managed conservatively or needs surgical intervention. Bowel obstruction can come in many different flavors. It could be acute, subacute, partial or complete, open or closed loop, and may be complicated by the presence of vascular compromise. If we look at the etiology of small bowel obstruction, most often the commonest etiology is postoperative adhesions. Other causes of extrinsic compression can include internal and external hernias, peritoneal carcinomatosis, and intraluminal causes include things like gallstone ileus, in our country, parasites, and sometimes foreign bodies. Ulceroconstrictive lesions like we see in tuberculosis or Crohn's disease, intussusception, which may be caused by a lead point, tumors, radiation-induced strictures, and ischemic strictures are other causes of small bowel obstruction. So this is the typical erect and supine radiograph of a patient presenting with vomiting, pain abdomen, and abdominal distension. You can see that we have dilated central air-filled loops. So small bowel lies in the center of the abdomen, shows us the presence of valvulae coniventes, which are complete rings which traverse the entire width of the bowel, and the valvulae coniventes are placed very close to each other. Contrast this to the presence of hostrations. Hostrations only indent part of the lumen of the gut. The large bowel tends to frame the small bowel by lying in the flanks of the abdomen, and you can distinguish the large bowel and the small bowel by the presence of valvulae in the small bowel and hostrations in the large bowel, which are placed wider apart and do not traverse the entire width of the lumen. So you have central dilated jejunal loops in the abdomen. You do not see much of terminal ileum, and you have multiple air fluid levels, again, located in the central abdomen. This tells you that you're dealing with small bowel obstruction. On the erect radiographs, we look for air fluid levels. More than 2 to 3 air fluid levels are abnormal. And then we can look at the width of the air fluid level, which should be more than 2.5 to 3 centimeters. And if the height of the air fluid level is more than a centimeter or 2 within the same bowel loop, that also suggests that that is a significant air fluid level. Here's a radiograph, erect chest radiograph, showing you a large amount of pneumoperitoneum underneath the right dome. This is a scout of a CT scan study, where you can see a large volume of extraluminal air filling the entire abdomen in this patient. CT, as I referred to earlier, provides a wealth of information. You can sometimes pick up things like telescoping of bowel, which is referred to as intussusception. Then there's an important sign, which is called the small bowel feces sign. And the small bowel feces sign is an appearance of fluid as well as mottled air lucencies, mimicking the appearance of colonic contents. When we see this in dilated small bowel, that is the point of transition, and it helps us to identify the site of obstruction, because wherever you see this small bowel feces sign, that is the point where the transition is going to occur. And this is well highlighted by this patient, where you have a dilated jejunal loop showing you this mottled air lucency, and then this changes over to collapsed jejunal loop. So this is the point of obstruction. Closed loop obstruction, as I referred to earlier, is a very significant and ominous clinical condition which needs to be identified very quickly by the radiologist. Here you have 2 points along the course of bowel that are obstructed at a closed single location. There could be more than one transition point. You have a C-shaped arrangement or a U-shaped arrangement of bowel, or radial configuration of bowel loops. The affected loop is markedly dilated, usually more than 4 centimeters in size. You have a twisted appearance of the gut, and you see stretched mesenteric vessels. This is a condition which is frequently complicated by vascular compromise and therefore needs rapid identification from the radiologist. How do we identify vascular compromise? Clinical features of ischemia are again non-specific. Things like fever, tachycardia, and acidosis can be seen but are not very reliable. A meta-analysis published recently showed that CT has a sensitivity of about 83% and a specificity of 92% in diagnosing the presence of vascular compromise. We look for bowel wall thickening. On a non-contrast scan, if you see hyperdensity in the bowel wall, that suggests hemorrhage. Hemorrhage within the bowel wall is a feature of ischemia. Altered bowel wall enhancement, it can have a very variable pattern depending on at what time you're doing your imaging. You may see reduced enhancement, and sometimes because of reperfusion, you may also see an abnormally increased enhancement. Presence of mesenteric fluid and stranding in this context, vascular engorgement, and of course, pneumatosis, free intraperitoneal air, and portal venous gas are, of course, late findings of ischemia and are very ominous signs and portend a very high mortality. Important to remember that certain causes of obstruction are more often associated with ischemia, and these are closed loop obstructions like volvulus, strangulated hernias, and obstructing masses. So let's look at some examples. Here's a patient who has dilated small bowel loops. You can barely identify any enhancement in these loops of bowel, and that suggests that these are ischemic loops of bowel, and this is something we need to convey to our surgeons very quickly. Another example where you have dilated bowel loops, almost the bowel wall cannot be identified at all. There is no enhancement, and on lung window, it becomes easy to identify the presence of intramural air in the dependent part of the bowel wall. When the bowel wall becomes papery thin and not seen at all, this is the harbinger of perforation, and again is a very ominous sign. Adhesive obstruction is one of the commonest causes of small bowel obstruction. Adhesions occur very frequently after abdominal surgery, but only about 5% of them actually get complicated by clinical bowel obstruction. The highest incidence is said to occur after colorectal surgery. They can present even in the immediate postoperative period and may also present even a few years later. The signs which predict the need for surgery in this clinical context include free intraperitoneal fluid, mesenteric fat stranding, high-grade obstruction, and absence of small bowel feces sign. People have said in studies that once you see small bowel feces sign, it's likely that the patient may respond to a trial of conservative treatment. Here's a 73-year-old man who presented with symptoms of bowel obstruction, had history of previous laparotomy, and we could see multiple air fluid levels in the central abdomen and mildly dilated bowel loops. When we did a CT, we saw that the jejunal loops were all dilated. We could identify the presence of small bowel feces sign here by the presence of this mottled air lucency in this fluid-filled loop. When we traced this, we saw that the small bowel loops were adherent to the undersurface of the abdomen. This was the site of the parietal adhesion in this patient. And this kind of patient may actually respond to conservative treatment. The old paradigm for bowel obstruction used to be, surgeons used to say, never let the sun set on an obstructed bowel. But over the last decade, there's been an increasingly trend towards conservative management of adhesive small bowel obstruction. And that is where the radiologist can sometimes play a useful role in trying to predict whether a conservative trial will succeed or not. There's another patient where you have dilated jejunal loops, and you have a kinked appearance of these collapsed loops of mid-jejunum, which suggests the presence of adhesions. When you diagnose adhesive obstruction, there is some role of giving a gastrographin challenge. A gastrographin challenge is given by giving diluted, ionic, iodinated contrast orally to the patient, about 200 to 300 ml, taking serial radiographs at 2, 4, 8 hours. And this not only can give you the site of obstruction sometimes, but because these agents, these contrast agents, produce an osmotic gradient in the bowel lumen, they may actually help to relieve the bowel obstruction. And this, once you give a gastrographin challenge, surgeons would usually wait for about 24 to 48 hours to see if the obstruction gets relieved, of course, keeping a keen watch on whether any ischemic signs develop or not. Here's a patient who has thickening of the ileocecal region, and there is a stricture in the ileum here, which is showing enhancement. You have adjacent lymphadenopathy. If you see necrosis within these lymph nodes, you can diagnose a stricture due to tuberculosis. This is a follow-up patient of inflammatory bowel disease, Crohn's disease, where you have this trilaminar enhancement of a loop of ileum with upstream dilatation, suggesting that this is an inflammatory stricture in the small bowel. You can also get fibrotic strictures after therapy in patients with IBD. Here is a narrowing of the ileal loop with homogeneous enhancement. And there is no trilaminar pattern seen here. So this is likely to be a fibrostenotic phenotype of Crohn's disease. Hernias are the other cause of obstruction. They could be both internal or external, can occur at different sites, inguinal, femoral, or obturator. Without going into the theory, let me show you an example. Here's an erect and supine X-ray of the abdomen where you have dilated small bowel loops, you have multiple air fluid levels, and usually on an X-ray, you should always include the hernial sites. The hernial orifices should be included in your radiographs. We do a CT in this patient, and you can see that there is a loop of small bowel which is herniating into the inguinal region, and this was the cause of obstruction. Obturator hernias occur more often in elderly women. Here, the herniated loop lies between the obturator externus and the pectineus muscle, and this is more commonly seen on the right side. Intussusception, where there is telescoping of one part of the gut into a distal part, may be caused by a tumor, which acts as the lead point. And on CT, we diagnose it by the presence of mesenteric fat within the lumen of the gut. Here's a patient. Again, the CT scout showed us dilated small bowel loops. CT axial images confirming the presence of these dilated loops. You come to a point where you start seeing fat within the lumen of the bowel, which suggests intussusception. And at the lead point of the intussusception, you have a tumor. This was a gastrointestinal stromal tumor, which had produced intussusception and presented with bowel obstruction. Adenocarcinoma is an uncommon cause of small bowel obstruction. You can see here asymmetric wall thickening, very nodular mass-like thickening with upstream dilatation in a patient who presented with adenocarcinoma causing obstruction. Midgut volvulus is a condition that is usually seen in the pediatric age group, but sometimes can be seen in young adults as well. Notice this kind of a whorl sign of the mesenteric vessels producing upstream dilatation. This is the coronal reformatted image showing you the twisted splanchnic vessels, upstream dilatation of vessels. This is the barium follow-through appearance, the typical corkscrew sign produced by midgut volvulus. Sclerosing encapsulating peritonitis, which was earlier referred to as a cocoon, common causes of which are idiopathic, tuberculosis, some drugs, can sometimes present with obstruction when there is a thick peel of peritoneum surrounding the small bowel loops. These loops then get obstructed. This is an unusual appearance in today's time where there is Ascaris. The worms are filling the lumen of the gut, presenting with bowel obstruction. If you have a combination of findings of pneumobilia, dilated small bowel, a lamellated calcified appearance in the distal ileum, you can diagnose what is called as gallstone ileus, where a calculus has eroded into the small bowel, and then it gets stuck at the narrowed part, which is in the terminal ileum. This is an unusual cause of obstruction. Here, a foreign body had eroded into a jejunal loop. This is actually a gossipiboma, which had eroded into the lumen of the jejunum and produced obstruction. And you can see the sponge being taken out perioperatively by doing an enterotomy. Let's move on to large bowel obstruction. The etiology of large bowel obstruction is very different from small bowel. Here, tumors tend to be the commonest cause. And of course, we have volvulus, both sigmoid and cecal. And let me just quickly show you some examples. This is the typical plain radiographic appearance where you have an inverted U-shaped appearance of a hugely dilated loop of large bowel in a patient with sigmoid volvulus. If you see a dilated loop of bowel, which could lie anywhere in the abdomen, and you see background findings of small bowel obstruction, always think of cecal volvulus. This is another patient where you have this hugely dilated inverted U-shaped sigmoid colon, and CT shows you the point of twist. This is a closed loop obstruction. You can see the twisted mesocolon here at this point and the inverted U-shaped appearance of the sigmoid volvulus.
Excuse me, sir.
Yeah.
Sir, probably need to summarize.
Okay, I'm just coming to the end of my talk. Yeah. Okay, so this is a patient with small bowel obstruction. You have a dilated cecum lying here in the upper abdomen in a patient who had cecal volvulus. This is the torsed cecum lying in the left upper quadrant. This is a patient with a large bowel obstruction produced by a sigmoid a mass in the region of the sigmoid colon. Another patient where you have an irregular mass in the region of the splenic flexure producing a large bowel obstruction. So conclude by saying that bowel obstruction is a common and challenging problem where imaging plays a very useful role. CT is the modality of choice. The main role of a radiologist to identify the transitional zone, which gives us the site of obstruction, likely cause. And of course, one of the main jobs is to see if there is any vascular compromise or not. And with that, I thank you for your attention.
Thank you, sir, for very extensive discussion, extensive coverage on the topic. We can have one question from the audience from the hall. Yes, please.
It is always necessary to do a contrast, or do we have to go a non-contrast CT prior to going with a contrast CT in a suspected intestinal obstruction?
So if you're talking of IV contrast, no, we don't do a plain scan. Usually we will straight inject IV contrast and do the CT. We do not use any oral contrast.
So any role of the non-contrast CT in case of intestinal obstruction?
I would do non-contrast CT only if the renal parameters were deranged. Because you cannot comment on bowel viability if you do not use IV contrast. People have in the literature published the role of non-contrast CT to pick up bowel hemorrhage, intramural hemorrhage in the bowel wall, which is a sign of ischemia. But you can usually diagnose that even on a contrast-enhanced CT. And if you have the luxury of doing a dual energy CT, then you can generate virtual non-contrast images.
Thank you so much, sir. We really enjoyed the talk.
Thank you very much.
We now move on to the next talk. This is by Dr. Pankaj Gupta. He is going to talk on percutaneous biliary drainage. He is from PGI Chandigarh. Earlier, he was in Department of Gastroenterology, now the part of main radiology. He is very, very accomplished intervention radiology and has an excellent hand for the percutaneous interventions. Dr. Pankaj, please.
Sir. Thank you for the invitation. I'll be talking about percutaneous biliary drainage. Biliary obstruction is an important cause of presentation to the emergency, and there are several causes, both benign and malignant, most common being choledocholitis and hepatobiliary malignancies. These patients commonly present with acute cholangitis, and in patients who have moderate to severe cholangitis, an early or an urgent biliary drainage is frequently required. We have several methods for biliary drainage, including ERCP, percutaneous biliary drainage, endoscopic ultrasound-guided drainage, and surgical drainage. Regarding percutaneous drainage, it is the preferred method for drainage in patients who have hilar obstruction, and is frequently the second-line method for distal obstruction. Besides cholangitis, which I have already highlighted, there are several other indications for biliary drainage in the emergency setting, and these include patients who have unsuccessful ERCP, biliary leaks, and biliodigestive and osmotic stricture presenting with cholangitis. So this is one of the examples where we can see that patient had surgery and there is a bile leak presenting as a biloma with biliary obstruction. Another example of a patient who has a biliary stricture at the edges site. Before I go into the PTBD procedure per se, there are certain important imaging findings which intervention radiologists need to identify. And these include confirmation of obstruction. As can be understood, diagnosis of biliary obstruction is straightforward in most of the patients. However, in scenarios, particularly edges site stricture, the dilatation may be minimal and hence not identified on ultrasound or CT. In these patients, MR, CP can illustrate obstruction well. Another scenario where patient has undergone a failed endoscopic drainage and presence of pneumobilia, these patients also are difficult to identify on ultrasound. And CT can be a useful modality for diagnosis of biliary obstruction in this scenario. Regarding the level of obstruction, this is one of the most important jobs of a radiologist prior to drainage, as it will define the modality of drainage in the initial setting. Not only the primary confluence, but the patency of secondary confluence should also be documented. So for malignant hilar obstruction, we follow the bismuth classification. Type 1 stricture where the primary confluences are involved, and type 4 stricture where bilateral secondary confluences are involved. So the extent of involvement is very important to identify. Similarly, for benign strictures, we need to classify the length of stricture from the primary confluence, which will define the mode of treatment. Ultrasound requires a greater degree of expertise to delineate the involvement of the secondary confluences. However, in this patient, we can see that the bilateral secondary confluences are involved. Coming to the causes of obstruction, the important causes of obstruction in emergency setting include biliary strictures, choledocholithesis, bile leak, and iatrogenic obstruction presenting as cholangitis. Other important scenario in our setting, particularly in North India, is the gallbladder cancer presenting with biliary obstruction, cholangiocarcinoma, and pancreatic cancer. Imaging also helps to identify the signs of cholangitis, which could be a heterogeneous enhancement of the liver, bile duct enhancement, and presence of cholangitic abscesses. Besides these particular features which must be identified, a coagulogram should be corrected if it is deraged. Patient should be given pre-procedure antibiotics and pain relief, and ultrasound, particularly for ascites, should be done. As in the setting of ascites, PTBD has a greater rate of complication as well as failure rate. As in this example, one of our patients who had ascites and a failed ERCP, PTBD was attempted without drainage of the ascites. After successful biliary access, the guide wire could not be negotiated because of the ascites. So in our scenario, what we usually follow, if patient has a moderate to gross ascites, we attempt a therapeutic paracentesis. If that fails to relieve perihepatic ascites, patient undergoes an ascitic PCD prior to PTBD. In most of the centers worldwide, a combined ultrasound and fluoroscopy guidance is utilized. However, in certain centers, for right PTBD, only a fluoroscopy guidance is utilized. And a recent study tried to compare the outcomes of patient undergoing fluoroscopy guided versus ultrasound guided procedure. And it was seen that patient who underwent fluoroscopy guided procedure, which would rather be a blind procedure, had a higher rate of major complications. Now, regarding the selection of duct right versus left, that's another important question which is frequently asked. So for patients who have indications of pre-operative drainage, pre-chemotherapy drainage, or cholangitis, unilateral drainage is invariably sufficient, as it is able to achieve drainage of more than 25% of the liver. In patients who have ongoing cholangitis following unilateral drainage, a bilateral drainage may be mandated. There are other situations where a particular duct should be selected. For example, in this particular patient who had marked atrophy of the right lobe, underwent a left PTBD. In another patient, who had left lobe atrophy, a right PTBD was done. Similarly, there could be lesions or masses in the needle path which may mandate the contralateral PTBD. Right PTBD is usually associated with significant patient discomfort. There is high risk of breach of the pleura, as well as the procedure is technically difficult. So if a patient has no indication for a specific side of drainage, I would prefer to do a left PTBD. Also, a few studies have shown that quality of life in patients with right PTBD is poorer as compared to those with left PTBD. Some patients may require multiple PTBDs, including even 3 or 4 PTBDs. For example, this patient who had a hilar cholangiocarcinoma had cholangitis, which did not resolve after a unilateral PTBD. So he was given a bilateral PTBD. Another patient who had perihilar cholangiocarcinoma with isolation of almost all the ducts on both sides underwent 3 PTBDs. This was a recent study from our center where we showed that patients who have cholangitis in the setting of hilar obstruction frequently require a bilateral PTBD. Now, it is important to understand that certain patients, the procedure may be challenging, and it is important to utilize hardware specific for that procedure, particularly the use of thin needles and wires and smaller pigtail catheters can be utilized. Following access to the ductal system, it is important to identify that the needle is actually within the ductal system, because placing a catheter within a vascular system or within the liver parenchyma may lead to complications. So biliary opacification is seen as the free flow of contrast away from the needle towards the hilum versus a rapid dissipation of contrast and contrast graining in patients who have vascular opacification or contrast extravasation into the liver. It is also important to understand that a very minimal amount of contrast should be injected, particularly in patients who have moderate to severe cholangitis, and if possible, no contrast should be injected if the operator is comfortable doing PTBD without contrast injection. The negotiation of site of obstruction is important to internalize the catheter, as a catheter which is left to external drainage is liable to get slipped and lead to complications. And this is facilitated by the use of angiographic catheters and the decompression of the ductal system. So frequently 2 sessions may be required to achieve internalization. As in this patient, she had a gallbladder cancer at the neck. At the initial PTBD, the catheter was going into the gallbladder and the internalization could not be achieved. However, in the subsequent session, both right and left PTBD catheters could be internalized, but patient had to be another PTBD had to be performed because of ongoing cholangitis, and subsequently all 3 PTBD catheters were internalized. The further management would depend upon the underlying condition. In patients who have unresectable malignancy would be offered self-expanding metal stents, and patients who have benign strictures will be subjected to balloon dilatation and catheter upsizing. In some patients in whom PTBD is performed as a salvage, prior to ERCP may be placed plastic stents for facilitating further ERCP. The major complications following PTBD are bleeding, cholangitis, and bile leaks. So this is one of our patients who had recurrent gallbladder cancer and omental metastasis. Presenting with cholangitis, a left PTBD was done. However, it could not be internalized, and later patient developed ongoing cholangitis, for which a right PTBD was done. As the left PTBD was not getting internalized, multiple attempts to internalize it and even new punctures were done that led to bleeding. And a CT angiography was performed, which did not show any arterial or venous bleed. However, one can note that there is a significant perihepatic hematoma as well as pelvic hematoma. This patient was managed conservatively in the ICU and she recovered, and following that, internalization and bilateral SEMS was placed. So in a patient who doesn't respond to conservative management, CT angiography is required, and if these patients have arterial source of bleeding, angioembolization should be done. The other important complication of PTBD is a new onset or worsening cholangitis. And as in this example, this patient initially underwent a left PTBD. However, there was ongoing worsening cholangitis. So she was offered both right posterior and inferior ductal system PTBD. There was development of cholangitic abscesses, for which even a percutaneous drainage of the abscess was done. Bile leaks are other dreaded complications of PTBD, and in these two examples, we can see that the externally placed catheters have slipped. In another patient who has PTBD catheter in situ, there is leakage around the liver from the catheter side. There is also a perihepatic catheter placed for biloma. And these present as localized collection of bile, as in this patient, or there can be frank biliary peritonitis. So it's very important to avoid this complication by early internalization, and patients should be stented if they are unresectable as early as possible. The other complications are the skin infections and electrolyte disturbances. These are very common, though under-recognized by the radiologists. The other less common complications are pneumothorax, hemothorax, bowel injury, and acute pancreatitis. PTBD has a high technical and clinical success rate. However, as we have seen, complication rates are on the higher side. These can be avoided by meticulous technique and regular follow-up of the patient. The reintervention rates are high, and I am referring these in context of the endoscopic drainage and US guided drainage. Now, there are few special situations like PTBD non-dilated system, and it has been shown that non-dilated system PTBD has a lower technical success as well as a higher risk of bleeding as compared to that in a dilated system. This was an experience from our center where we recruited 57 patients, and it was a retrospective study where we found that the procedure was technically successful in more than 90% of the patients. There were major complications in 2 patients in the form of biliary peritonitis. So in such a scenario, an important alternative that must be remembered is a percutaneous cholecystostomy. Although it is not the upfront choice for drainage of biliary system and is usually done in patients with severe polycystitis, but this is an important salvage option as it has a high technical success and clinical success, particularly in patients with cholangitis. Bedside PTBD is also feasible, and in one of our studies, we had 10 patients in whom procedure was technically successful in all patients. However, clinical success, as expected, would be low because of the severe progressive condition of these patients. To conclude, PTBD is an important emergency intervention radiology procedure, and its importance as a salvage procedure is being increasingly recognized because of the increasing number of endoscopic and endoscopic ultrasound guided procedures. It has a high technical and clinical success rate. However, the complications need to be reduced by meticulous technique and appropriate follow-up. Thank you.
Thank you, Dr. Pankaj. Very nice talk. We can take a couple of questions from the house.
Sir, do you decide the size of the PTBD according to the how much the system is dilated? If it is not so, then sometimes we have seen the system is very, very dilated and the PTBD slips out. And then next time we put a thicker bore PTBD. So what the rationale behind that?
Usually, our institutional practice is to place an 8 French PTBD catheter. And as I said, if patient has a non-dilated system, then sometimes we put a 6 or 7 French catheter. Slippage is not really related to the initial catheter size. It's more to do with the lack of internalization. And what has been shown is that if we, rather than placing the curved catheters, if we place pigtail catheters, if we are not internalizing the first setting, may reduce the rate of slippage.
Sir, what is the ideal time for internalization, or how long we can keep this drainage, external drainage?
So internalization should be performed as early as possible, but in patients with severe cholangitis, because internalization would entail more of intervention or the manipulation. So except for patients who have severe cholangitis, internalization should be performed early because it will reduce the further risk of complications because of slippage of the catheter.
So in the absence of cholangitis, we can internalize on the same day.
It's done on the same setting.
Good afternoon, sir. So in procedures such as HGS strictures, we need to dilate. When you put the PTBD, how long do you need to give the interval, or you can do it immediately with dilatations if the patient is not in cholangitis? And if he is in cholangitis, then what do you do?
So there are several protocols that have been described, but we are following in our center is to initially place an 8 French catheter and balloon dilate in the first session. Then we call the patient serially, usually every 3 to 4 weeks, for catheter upgradation, which can be up till 18 or 20 French, which will usually take 4 to 5 months. And following that, we do a cholangiogram, and if we can document the patency of the HS site, we would remove the catheter. But there are variations of protocol in other centers who would do balloon dilatation and then remove the catheter even in the same session. But that has shown to be associated with more failure. There is also advent of biodegradable stents, where you can place a stent that would degrade on its own, and there is no need to keep long-term catheters.
Thank you, Dr. Pankaj. Thank you so much for a very nice talk.
Sir, can I ask a question?
I think you
Sir,
can. Okay.
Sir, are there any patient-related or catheter-related factors that increase the risk of PTBD slippage? Because we often discharge patients on PTBD once they improve with advice to follow up, but many times they call in the tele-OPD that their PTBD has slipped. So which patients will have to be more careful regarding follow-up?
So as I said, the patient should be on regular follow-up. I don't see any definite patient-related factors, except that if a patient is frail and is not able to take care of the catheter, obviously the catheter is more likely to slip. But as we understand that over time, the suture which we have placed will sort of break. So it is important to regularly follow up the patient every 4 weeks at least to exchange the catheter.
Now I invite Dr. Ujjwal from Radio Diagnosis. He is working there as an additional professor. His talk is on mid-gut bleed, role of a radiologist. Dr. Ujjwal, please.
Very good evening to everyone. So it's good to be on stage after 1.5 years of speaking in front of a screen from my office. First of all, I would like to thank Kocha sir and Usha ma'am for this opportunity. So in next 15 minutes, we will see what role a radiologist can play in mid-gut bleed. So I'll be discussing a little about imaging and more of intervention, and also we'll be discussing imaging findings while discussing the interventions. So the classification of GI bleed, this is, I mean, all gastroenterologists. So source of GI bleed, it is between the ampulla of water and the terminal ileum. So it is labeled as mid-GI bleed. So we suspect small bowel bleed when there is no bleeding site identified even after evaluation of upper and lower GI tract, which is typically with endoscopy. So in the algorithm of suspected small bowel bleed, if the patient is stable, like you are looking at a patient who has bleed and he's an OPD kind of patient. So in this patient, if CT enterography or MR enterography is done, so it is placed right here. When you are trying to proceed with small bowel evaluation, but you think that the patient may have a bowel obstruction, so you can go with the CT enterography and MR enterography. And also if video capsule endoscopy is negative, then you can go ahead and do a CT enterography or MR enterography. But the scenario changes if it's an emergency kind of situation, which we are dealing in this particular talk. So if it's a brisk, massive suspected small bowel GI bleed, patient is stabilized, and then red cell RBC scans, which is actually not done. We tend to perform more of a CT angiography, and if CT angiography is positive, patient is immediately taken up for catheter angiography or digital subtraction angiography, and if it is also positive, we will embolize in the same setting. If the patient continues to bleed and he cannot undergo CT angio and you are suspecting active bleeding, then you can directly take the patient for catheter angiography also. So use of radiographic examination. So there is this is a a brief idea that barium studies are not performed nowadays. CT enterography, as I just told you, in OPD kind of setting, whereas in acute overt massive GI bleed, conventional angiography directly. Conventional angiography should not be performed as a diagnostic text in patient without overt bleeding, because it has been seen that if the patient is not bleeding actively, then you won't find anything on catheter angiography. If patient is hemodynamically stable and there is evidence of active bleeding, it is good practice to do a CT angiography first, because you can localize the site from where you are likely to get the source of bleeding, which can be very difficult to find in a patient who is in shock and you are taking directly patient for catheter-directed angiography. So acute overt GI bleed, when the bleeding rate is very, very slow, or you are uncertain that there is an active bleed or there is an intermittent bleed, then the patient can be offered tagged RBC scintigraphy. Younger patient, Meckel scan can be performed to rule out Meckel's diverticulum. And the three investigations which are there, the highest sensitivity to pick up is actually by 99M technetium scintigraphy RBC scan. It can pick the bleeding rate at low as 0.1 to 0.5 ml per minute. However, the problem with this is poor localization. It cannot exactly pinpoint the site from where bleeding is happening. And the second point is it takes time. It cannot be done immediately. Conventional angiography will pick up bleeding at the rate of 0.5 to 0.1 to 1 ml per minute, and CT angiography is in between. It will pick up the bleeding at the rate of 0.3 to 0.5 ml per minute, and it can be done within minutes. So CT evaluation of acute GI bleed, CT is actually the workhorse, especially in emergency setting. You can evaluate the lumen. You can also see for the bubble loop, mass, any thickening, extraintestinal pathologies, vascular anatomy, because sometimes there are vascular abnormalities. If there may be celiac axis which is blocked, there may be SMS stenosis. So before taking catheter, this patient for angiography, it's good if you know this vascular issues, and we can perform or plan a procedure accordingly. So then CT can help you in choosing next most appropriate intervention, whether it's patient should go endoscopy, fluoroscopic angiography, or surgery. CT methods to evaluate GI bleed, CT angiography in emergency setting, and multi-phase CT enterography in outpatient setting, which I just told. So CT enterography in GI bleed, oral intake is withheld for 4 to 8 hours, 2 packets of polyethylene glucanol, 2 liters of water. They are given in 30 minutes. After that, IV contrast is given. And if an GI bleed is suspected, then the triple phase helical scanning from diaphragm to symphysis pubic is done. That is, first you perform NCCT, then arterial phase and a portal venous phase. If you have dual energy CT, then you can omit NCCT and you can generate virtual non-contrast images either from angiography or portal venous phase. So these are just to show image how good bubble distension can be obtained by CT enterography. Whereas in CT angiography, there are important points which we should know, that you don't need and you don't give oral contrast. There is no need of oral contrast. Positive oral contrast is not given because it will obscure luminal iodine extravasation, which is actually the key to the diagnosis of the patient who will undergo catheter angiography. Neutral oral contrast is also not given, which is given in CT enterography, because it takes time to drink that water, and then the possibility of diluting the extravasated iodine. So iodine which is extravasated may get mixed with this contrast and you may not be able to see it clearly. IV administration of contrast is must, and it is given in all the patients. So in CT angiography, as I told, images is done in 3 phases. Non-contrast is acquired because if non-contrast is not acquired and you see something in the lumen, you don't know whether it was present before angiography or it has now extravasated into the lumen after you have given the contrast. So it acts as a baseline. Then there are certain things which can mimic, like something injected particles, some clot. So to differentiate that, NCCT is actually a must if you are doing a CT angiography. Then we perform arterial phase to see for extravasation, pseudoaneurysm, and in portal venous vein, this extravasation becomes more prominent. I'll be showing you these images later in the course. So then there are 2 important points. If you get a positive result on CT angiography, then you will get a positive result in fluoroscopic angiography. This is in our practice we have seen every time. Important thing is that the time difference between the CT angiography and DSA should be as little as possible. Studies have shown that if you increase this time, that you may not find the bleeding when you take the patient for catheter angiography, just because bleeding can be intermittent. And if CT angiography is negative, it gives you good prognostic information, as the patients with negative findings are unlikely to need any emergency surgical or angiographic intervention. So common cause of acute small bowel bleed less than years and 40 are different. So most of these causes inflammatory bowel disease and tumors. They have their characteristic imaging appearance as well as not present typically in emergency setting. So I will not be covering them. So we'll be discussing with the vascular pathologies with which the patient may present and the patient which land in emergencies. So indications for interventions, radiological intervention, if a mid-GI bleed is suspected which does not respond to medical and endoscopic therapy, if the patient is hemodynamically unstable or the patient has visceral pseudoaneurysm. Angiographic findings can be many: extravasation, pseudoaneurysms, tumor will show you blush, angiodysplasia or Danafer's lesion. IA techniques can be endovascular. In endovascular, you can either embolize. Embolize means you can block the artery, or stent graft, you can keep the lumen of the artery patent, or in some patients, you can directly under ultrasound or CT guidance, you can inject either thrombin or glue. Embolic agents are many. They can be temporary, permanent. Most common used are coils, and in some certain situations, gel form and PV particles are also used. So there are certain principles when you are doing embolization in GI. So first, if there is a bleeding and the bleeding artery is non-vital, you can embolize that whole artery if there is a good collateral circulation. Embolize super selectively, go as close to the point of the bleed as possible so as to avoid ischemia. Prevent retrograde flow in the embolized vessels because good collateral circulation can cause refilling of the pseudoaneurysm or extravasation. If artery is vital, cannot be sacrificed, put a stent graft. If it's tumor, don't block the efferent artery, reach till the tumor bed and block that. Otherwise, if you block only the efferent artery, the tumor is going to recruit vessels from other vessels and patient will have rebleeding. Similar is with AVM, arteriovenous malformation. You have to go till the nidus and embolize it. Percutaneous route can be done if it is safe and feasible. So this is just an SMA angiogram. It shows you the different levels at which bleeding can be here. So this is at the level of vasa recta. So sometimes bleeding can occur at this. Studies have shown that you can embolize up to 3 vasa recta without chances of ischemia or infarction. But if you tend to embolize more than 3 vasa recta, then the patient may develop bowel gangrene or infarct. If it is at somewhere here, like it's in the proximal, jejunal or ileal arteries, then you have to embolize both distal and proximal. Okay. Otherwise, if you embolize only proximal, patient will have recruitment from this side and patient will bleed. And if it is a main SMA trunk, you cannot embolize whole of SMA. So you have to put a stent graft. So this was a patient with vasculitis presented with the rapid progressive renal failure, melena, sudden drop of hemoglobin and increasing melena. So what you see is there is an arterial phase, you see contrast excitation in the bowel. So no oral contrast has been given. If oral contrast has been given, you would not be able to pick up this excitation. It changes the shape in the venous phase, and these are the VRT images where you can see this contrast excitation. So patient was taken up for DSA. Here you can see this beaded kind of appearance, which is typical of vasculitis. So in this patient, it's difficult to cross the microcatheter, but with little difficulty we could reach here. So here is the active contrast excitation. You reach as close to it as possible and embolize, and this is post-embolization run. So another patient presented with massive bleed, and what you see here is there is a leak from the lateral wall of the aorta. There is this big, large hematoma. So this contrast is exacerbating into this hematoma, and here you can see that there is a rent here in the D3 of the duodenum, and then this contrast is going into the D3 and D4, and on the delayed images you can see this contrast is seen in the jejunum. So this is aortoenteric fistula, a dreaded complication, but CT angio will pick up. This patient actually, unfortunately, died just after the CT angio, and nothing could be done. Another patient, middle-aged woman, diabetic mellitus, hypertension, painless, massive melena. So this is the NCCT phase. This is the arterial phase where you can see contrast excitation, and on venous phase you can see this contrast excitation. It is still in the bowel, but it has changed its shape. Pseudoaneurysm will remain of the same shape, whereas extravasation will change. So if you don't require portal venous phase, if the flow is very less, arterial phase may not be able to pick it up. Okay, so portal venous phase has to be done, and NCCT has to be done when you are suspecting a GI bleed. So these are the MIP coronal images where you can see that there is a bleed here, and it's probably rising from one of the general branch, and it has increased on the delayed phase images. So this is actually the images which is from our hybrid CT, where we can on the DSA table we can cannulate the artery and we can take the CT images in the same sitting. Okay, so this will help us giving the diagnosis as well as localizing the site of bleed. So here we can see that you see that there is this small artery here. So instead of decreasing in caliber, this artery here is increasing in the caliber as compared to the rest of the vessel, and it is also slightly irregular. So again, you see this is the this abnormal artery here, and then there is active contrast excitation. So imaging wise, it looked like a Delphi's lesion. So we went ahead, did DSA. So this was the as main SMA run, then we reach selectively into this artery. So you can see extravasation here. So then we try to go as close to the extravasation as possible. So this is the site of extravasation, and this is the position of the microcatheter, and from here you can inject just a little glue so that you remain within the 1 vasa recta, there is no ischemia, and this patient recovered well. Another patient, this patient had history of trauma, and you see there is a pseudoaneurysm which is arising from proximal SMA, so you cannot embolize the main trunk of SMA as such. So in that patient, this is again a diagnostic run. You can see that there is extravasation from SMA. So you cannot, during DSA run itself, the pseudoaneurysm got ruptured. So we put a implant superstiff guide wire, and then we put a stent graft over here, which preserves the flow to the SMA, and the pseudoaneurysm is no more filling. And here is the stent graft position. Another patient, diabetic mellitus type 2, pain in Dobbin, hematemesis outside endoscopy, showed fresh blood in stomach and duodenum. Source could not be identified, and scope could not be negotiated beyond D3. Patient was referred to PGI. So here we can see another this irregular lobulated aneurysm in superior mesenteric artery. So you can see the pseudoaneurysm here, and then this is on VRT images where you can see the pseudoaneurysm. So the problem here is that this pseudoaneurysm proximally is the main trunk, but distal to the pseudoaneurysm, there is not single artery where we can put a stent graft. So there are 1, 2, and 3 arteries which are arising from the pseudoaneurysms. So you cannot put a stent graft here because of size discrepancy and because of absence of landing zone. So if the patient has good collateral, if celiac axis is okay, IMA is okay, you can try and trap the pseudoaneurysm. So first I went into one artery, distal to the pseudoaneurysm, coiled it, then into the other artery, coiled it, then into the third artery and coiled it. Then I came proximal and I embolized the SMA trunk. So you would think that patient may have ischemia, but usually it won't happen if celiac and IMA are patent. So in this patient, you see we have blocked SMA trunk, these small branches, but then when I take the SMA run, there is a good collateral circulation and good flow is maintained. So this is the kind of innovations you can do if you are dealing with the atypical situation. Sometimes pseudoaneurysms like this here, small pseudoaneurysm, it was arising from a small branch of SMA. We tried to cannulate it. It was very small artery, we couldn't cannulate. So we saw it on ultrasound. It was seen on ultrasound. So we just injected percutaneous 50% glue puncturing it with ultrasound guidance and then seeing it under flow. So another patient, young patient, melena, delicing abdominal pain, hemoglobin was less. So here we see that there is a tuft of vessels in ileocholic region. You can see that there is a artery which is supplying this region, and there is also an early draining vein. So this is arteriovenous malformation where you see an artery, you see a nidus, and you see an early draining vein. So this usually requires surgery, but if patients presents with the immediate emergency kind of situation, then angiography can be attempted. So this is the SMA run. You can see this nidus here, and you can also see this early filling of vein. So this was cannulated, and again it was embolized using glue, and bleeding stopped. Patient eventually underwent surgery on a later stage. So again, this metastatic RCC patient was operated sometime back, and he now presented with lower GI bleed. CT was done, so we see that in the renal bed there is this tumor mask here, which has infiltrated into the jejunal loop. So you can see that there is infiltration, and as we all know, RCC is a hypervascular tumor. So patient presented with continuous lower GI bleed. So this we planned was to do a tumor embolization. So this is again run of superior mesenteric artery. Then we cannulated this artery selectively. So important thing is you don't put coils here. Okay, so you have to reach till the nidus, and then you inject PVA particles or embospheres to block the tumor bed. So once the tumor bed is blocked, then usually these tumors don't have supply only from one branch. They will have multiple arteries. So you check for the other arteries. So you see that there is again an artery which is supplying this tumor. Using microcatheter, this was cannulated, and then this was embolized. And post-embolization, you don't see any filling of the tumor. So CT angiography, important diagnostic tool in emergency setting. It gives you information regarding the presence, location, and cause of active bleed. It also guides the choice of subsequent therapy. It can be endoscopy, it can be surgery, or it can be catheter angiography. Intervention radiology offers you a minimally invasive therapeutic option. Thank you for your patient hearing.
Thank you, Dr. Ujjwal. Now I invite questions from the House.
May I make one or two comments? If a patient of cirrhosis comes to us with a aneurysm in the hepatic artery or a branch of hepatic artery, then are there any chances of liver failure in cirrhotic patients if we do embolize the vessel? And how much we can avoid if we...
Like aneurysm arising from what? Where?
If it involves hepatic artery proper or branch of hepatic artery and a cirrhotic patient, if we can find an aneurysm, then are there any chances of liver failure?
See, that will happen, that will depend upon the status of the portal vein. If your portal vein is okay, then there are no chances of ischemia. Second thing, it will depend upon the arterial anatomy. If you have a replaced hepatic artery, which is arising from SMA, if you have a accessory left hepatic artery, which is arising from left gastric artery, ischemia will not happen. But if there is only a single hepatic artery, there are no collaterals, and if there is portal vein stenosis or occlusion, then infarction will definitely happen. So in these patients, only option which you have is putting a stent graft. If you can put a stent graft, if the anatomy is feasible, then it's okay. Otherwise, don't embolize.
Okay, thank you.
So if you have a given clinical scenario, like a patient has an ongoing melena, has a HB drop, and we do a CT angio, that is negative, sir. So what would be your second choice? That means patient has ongoing bleed, but it is coming as there is no ongoing bleed detected on angio. So would you repeat
in that algorithm, I'm not sure what is the practice which is followed in different, but in that algorithm, if it's a significant bleed, then you have to decide between enteroscopy or surgery, but definitely not catheter angiography.
We will not consider RBC scintigraphy.
RBC scintigraphy will depend upon, as I mentioned in that how much bleed is there. If it is ongoing bleed, if it's an ongoing bleed, but patient is stable.
Yes, he would be stable, but
he must dynamically stable, ongoing bleed, intermittent bleed, then yes, RBC scintigraphy fills that picture. But if the patient is unstable, then then you have to take a call accordingly.
Sir, in a patient with pseudoaneurysm without any active contrast leak on CT angio, what are the factors that help us decide whether we should go for a stent graft or coiling?
Active contrast excitation is not a feature. Second thing is between stent graft and embolization, two things. If it is from the main artery, if it's like SMA kind of main stem, as I mentioned that in slide, if it's a bleeding and the artery is vital, then you have to do a stent grafting. But if artery can be sacrificed, like it's a pseudoaneurysm which is arising from a gastroduodenal artery, you embolize it, nothing will happen because SPDA, IPDA, there are so many collaterals. So in that you can do embolization. Second point, sometimes which may end is cost. Stent graft is cost more than 1 lakh. So coiling, if suitable location, maybe you can get away with 30,000-40,000. So in that also you have to take into picture in our scenario.
There is no more question. We conclude the session. Thank you very much to all of you.
Thank you, Chairperson. Moving on to the next session. The next session is sponsored by Olympus. It is the endoscopic nightmares, what to do when. The chairpersons for this session are Professor Vikas Gupta, Department of Surgery, PGI Chandigarh, Dr. S.S. Rana, Professor, Department of Gastroenterology, PGI Chandigarh, and Dr. Ajay Gulati, Professor, Department of Radiodiagnosis, PGI Chandigarh. I request the chairpersons to introduce the first speaker.
So the first talk is going to be delivered by Dr. Praveen Rai. He's a professor in the Department of Gastroenterology at SGPGI, Lucknow, and would be speaking on post-cystogastrostomy bleed. Dr. Praveen, please.
Yeah, am I audible?
Yes, sir, we can hear you properly. Please go ahead.
Yeah, are the slides seen?
Yes, sir. Yes, sir.
No, we can't see your slides, sir. Yes, yeah, we can see the slides now.
Okay. So firstly, I'd like to thank Professor Usha Datta and her team for this opportunity. So I'm talking about post-cystogastrostomy bleed. So if we see this bleed, it's one of the most common complication of transmural drainage of pancreatic collections. The risk of bleed is around 1 to 10%. The bleeding related mortality is around 1 to 3%. Since we do most of the cystogastrostomy with EUS, so even after EUS and using Doppler, the risk of bleed remains. The timing of bleed is important, so we can have bleed during the time of the pancreatic fluid collection drainage, or it can happen after you have completed the procedure, maybe a day after. You can also have a delayed bleed, which is even weeks after the procedure, maybe 3 weeks, 4 weeks after the procedure. So once a bleed happens during the procedure, it's primarily related to the puncture site or due to tract dilatation. Why? Because there are small missed venous collaterals or pseudoaneurysm within the wall of the collection, which bleeds after rapid decompression. The bleed can happen from within the cavity, and this is related to the pseudoaneurysm in collection or the blood vessels with weakened wall coursing through the collection. And again, the bleed happens after rapid decompression. So if you see the first image, after applying color Doppler on EUS, this is the pancreatic fluid collection, you see there is vessel at the site of the puncture. So you need to avoid this. If you're going through this, you will likely have a bleed, which may cease spontaneously, or you may need some therapy. Again, this is one of our patients. You can see a walled up pancreatic necrosis and the vessels running across through the collection. So it's very important to see on EUS that there are vessels or not. And if you apply Doppler on this, you can see 2 large vessels running through this collection. And in this particular case, we chose to place a plastic stent, visualizing the vessels at all point of time, and the event was uneventful. So you can have a delayed bleed, and the mechanism of delayed bleed is once you deploy a lumen opposing metal stent, usually in patients with walled up pancreatic necrosis, what happens is the cyst wall collapses. Once a cyst collapses, then these flanges of the lumen opposing metal stents erode the surrounding vessels, which are usually gastroduodenal artery or the splenic artery, and these can cause massive bleed. These can happen even with plastic stents. So this was an elegant study which showed that the risk of complication increases as the duration of the LAMS in situ increases. So it increased after 3rd week. Before that, there was no bleed, but after 3 weeks, the risk of bleed increased. So this is again the LAMS placed in this particular case. The patient presented after 3 weeks, had massive bleed, and you can see this is the lumen opposing metal stent. This is a vessel which is adjacent to it. This was pseudoaneurysm due to lumen opposing metal stent, and you can diagnose this even on EUS, and obviously you need angioembolization or maybe other modality for treatment. As you can see, this is the metal stent, this is the aneurysm, and arising from the vessels. So this patient underwent radiographic angioembolization. So once we are aware that this can happen during the time of the procedure or at a delayed time, the management primarily is endoscopic with coagulation, epinephrine, clip, balloon tamponade, or hemospray. If there is a minor bleeding, it may cease on its own. That can happen just supportive management with fluids or with blood transfusions if needed. There is a significant massive bleed. If it happens, it usually needs some sort of intervention, which can be, if it's during the procedure, you can choose a fully covered metal stent that brings about the tamponade if the vessel is at the puncture site, or the patient may undergo a radiographic angioembolization to take care of the pseudoaneurysm. The rescue option is primarily surgical, which involves ligation of the culprit vessel. So this is again a published study. This is spontaneous cessation of bleed. As you can see, this is a clear pseudocyst. After the drainage with the plastic stent, patient had bleed, which showed blood in the collection, and endoscopy revealed minor bleed, which settled on its own. Another treatment modality is hemostatic forceps. As you can see, after drainage, the bleed when on endoscopy was found that there was a visible vessel at the puncture site, which was closed, sealed with hemostatic forceps. Another modality that can be used is a balloon tamponade. If you see, this is a pseudocyst, pancreatic fluid collection. You can see collaterals in the wall of the pancreatic fluid collection. And after on US, there wasn't any large vessel which was seen. However, this is the image. As you can see, large spurt coming out from the puncture site. And this bleed was taken care of by using a balloon tamponade. Another modality that can be used is hemospray. So if you can see here, there is a visible vessel which is seen oozing from the puncture site, and this can be taken care of by hemospray. So this is again one of the modalities which can be used, though we use this only once it is not controlled by other treatment modalities. So this is how hemospray is done. Again, for vessels over a large diffuse area, this is one of the treatment modalities that works. So this is one of our patients. As you will see here, this is a pancreatic fluid collection. What we do is puncture directly with a 10 French cystotome. This is a cystotome which is going inside the collection, and you will see as we're applying cautery, you can see a gush of blood here. So you can see a gush of blood as soon as we punctured. The puncture, however, was very difficult in this particular case. We used 10 French cystotome, as I mentioned, and as many times as we kept on puncturing it, you can see a jet of blood coming in the cavity. So this, after some time, this whole cavity was filled with blood, as you can see. And you can see this has become totally red. So what we did here is we did a balloon tamponade. It's a small balloon. Balloon tamponade, applied the balloon for around 4-5 minutes. And after application of balloon, we placed a metal stent to take care of this bleed by tamponade. So you can see this is a 3 centimeter long, 16 millimeter diameter metal stent which is being placed here. After this, the bleed settled. And as is usual, we place, you can see large amount of blood here. And after this, we placed a double pigtail stent, which is usually a 10 French 3 centimeters double pigtail stent across this metal stent to take care of the bleed. So as I mentioned, radiographic angioembolization is again one of the modalities. In this particular case, it is being used for stent-related erosion and the formation of a pseudoaneurysm, complete obliteration by radiographic angioembolization. So these are the different treatment modalities that are in place. So one more treatment modalities that we usually use in our center for pseudoaneurysm which are detected is EUS guided coil and glue. As you can see, this is a large splenic artery pseudoaneurysm. This was before we undertook this patient for drainage, and you can see the neck of the pseudoaneurysm, blood flowing through it. And what we usually do is puncture with a 19 gauge FNA needle, inject coil, 2-3 coils, whatever are needed to obliterate this aneurysm. And after coil, we instill glue in this pseudoaneurysm to bring about complete obliteration. So as you can see now, this is the coil which is going. So first coil is injected here, and then we inject a second coil because it's a large pseudoaneurysm. This was around 3.5 centimeters pseudoaneurysm. And after this, we inject glue. And what you will see after this is once you apply Doppler, the whole aneurysm is obliterated. So we found, we have done a number of cases, and we find this to be a very effective modality to take care of pseudoaneurysm. So color Doppler reveals no flow in the pseudoaneurysm. So we don't have very good literature on the bleed, so there are no large studies, and in majority of the studies, source of bleed is again unclear. There are heterogeneous treatment modalities, and what I've shown you is the different case scenarios, the different treatment modalities that can be used. However, there is an analysis of 926 patients who underwent pseudopancreatic fluid collection drainage, and the bleed rate was around 2%. What is important here is majority had been taken care of blood transfusion alone, while other significant proportion needed endoscopic therapy, while radiological or surgical treatment was offered only in 1 and 2 patients respectively. So in another systematic review, this was a review of 14 studies, not in drainage alone, but in endoscopic necrosectomy, and the complication rate here was high to the tune of around 18%. But what is important here is bleed was primarily in 93% controlled by endoscopic modalities alone. Radiological angioembolization was needed only in around 7%. So this slide just tells you the different case series that have been published. This study is a bit interesting. Lumen opposing metal stent, the bleeding rate 7% compared to a pigtail stent, which was only 2%. However, there are other studies which say that there is no difference in the complication of bleed between plastic or metal. So how do you prevent this bleed? So it's very important to look for the coagulation parameters before you drain these collections. CT angiography may be done prior to detect presence of pseudoaneurysm, which can be taken care of before you drain. During US guided puncture, the pancreatic fluid collection is mandatory to use color Doppler. This is to pick up vessels and to avoid that site. And you need to relax the US up and down knob. If you are pressing too hard on the knob, then the vessel, if sitting there on the wall, will be compressed and you will not be able to visualize the vessel. Needle knife needs to be avoided to create fistula after the initial puncture. We need to use a wire-guided cautery device or a graded dilatation to enlarge the transmural tract. And early removal of the metal stent after cross-sectional imaging. This early is around 3 to 4 weeks. So this is a treatment algorithm which has been suggested in a review. And what is important here is depending upon the cause of bleed, whether it's pseudoaneurysm, then the patient goes for radiological angioembolization. Though in our center, we will do an EUS guided embolization. If it's an intracavitary bleed, you do an endoscopic therapy. If it's an inadvertent puncture of the vessel, collateral vessel, or a stent erosion, and the bleed is only mild, then you resort to conservative measures. If it's severe, you can choose endoscopic option, which is clip, cautery, or tamponade. If it's uncontrolled, you go radiological embolization or surgery. Again, coagulation-related bleed is one of the important cause of delayed bleed, which one needs to remember. So to summarize, it's one of the most common complication of pancreatic fluid collection drainage. Despite EUS with Doppler, risk of bleeding remains. CT scan prior to drainage may be done for pseudoaneurysm. Use of EUS Doppler prior to puncture and avoiding needle knife is required. Coagulation, epinephrine, clip, balloon tamponade, or hemospray are the different treatment modalities which are used to control the bleed. Radiological embolization is required usually in cases of massive bleed. Metal stents may be used for intra-procedural bleed. Early removal of the metal stents at 3 to 4 weeks is needed after you do a cross-sectional imaging to document decompression of the collection. A multidisciplinary approach is usually warranted. Thank you.
To time and for a very nice and illustrative talk. And what it used to be a surgeon's domain about 15-20 years back has been taken over by multimodality and minimal invasive interventions. So with this comment, I will open the topic for discussion.
Sir, is there any vascular contraindication for cystogastrectomy? You showed one slide where there were two big vessels. Even in that patient, cystogastrectomy was done and managed successfully. So is there any condition where position or size of the vessel wherein you would not go ahead for cystogastrectomy?
Yeah, so I think if we have an established pseudoaneurysm, we would obliterate that first and only then take up these patients for pseudocyst drainage. In this particular case, I showed you, these vessels were seen even on CT. There was no pseudoaneurysm as such. So what we thought that we would drain this collection, and we chose to place a plastic stents in this particular case. We used plastic stents and could successfully drain. So if you have pseudoaneurysm, I think you should be obliterating that before you intervene.
So what is the optimal duration for which balloon tamponade is to be done? And the second thing is that you showed a visible vessel in which you sprayed hemospray. Why was not a definitive treatment chosen? Why was hemospray used in that setting? Because it is not a first modality of choice for any GI bleed cell.
Yeah, so I think the case of hemospray that I showed you is not mine case. It is one of the treatment modalities, which is a published case in the literature. What you are saying is absolutely right. One should resort to other measures before one think of using hemospray.
Dr. Rai, in a patient with segmental portal hypertension or collaterals in that area, how would you prevent? And if it bleeds, what would you do?
Yeah, so I think segmental portal hypertension, what usually we have left-sided portal hypertension, if that's the case, there are multiple collaterals around. So if on EUS and the pancreatic fluid collection I'm seeing on EUS, the wall is totally free of collaterals at that particular site, I think I would go ahead and drain, preferably a plastic stent, and then I think it usually does the job. So I don't think anything specific is needed in this particular case, unless you have a collateral or a large vessel sitting in your tract, then you need to avoid that.
Sir, till now we don't have data to say the metal stent are superior over plastic stent. For the subset of the patient who have multiple collaterals, and plastic stent we require a large balloon dilatation. In metal case, we don't require. So we can say that for this subset of the patient, metal stent are superior over plastic stent.
Yeah, so if you review the literature between plastic and metal, I think it's a lot of debate.
45 minutes of jump.
So we have too many studies which suggest that there is no clear-cut answer that plastic or metal, one of it is superior to other, especially for pseudocysts. So you can choose plastic stent does the same job as metal. However, what is logical is if you see a walled off pancreatic necrosis, the metal stent obviously provides you an edge. Once you are trying to do a necrosectomy in this particular group of patients, doing necrosectomy with plastic stents in place is quite difficult. Every time you need to remove those stents, dilate the opening and then proceed. While with metal stents, you can easily go in and come out easily without dislodging the stent as well. So I think, again, we have a well-designed study which tells that you need to use plastic or metal. You can choose either in pseudocyst or in walled off pancreatic necrosis.
So in case of an intra-procedural bleed, when we use stent tamponade as a modality to control the bleeding, will that predispose to dislodgement of the metal stent? Because we have just put the metal stent and
Yeah, so I think one needs to understand is that what we usually do is puncture with a 19 gauge FNA needle, do a minimal dilatation, maybe a 4 millimeter hurricane or 6 millimeter hurricane, or as we do, we directly use a 10 French cystotome. So that dilatation is not large dilatation, and even a 8 to 10 millimeter CRE may be sufficient. And then finally, what you're deploying is a stent, which usually is a 14 or 16 millimeter stent. The risk of migration again would be less. Moreover, as I showed, that in all these cases, you end up deploying a plastic stent across the metal stent, the primary function of which is to prevent migration.
Thank you.
Thank you, Dr. Praveen Rai, for an excellent talk and showing some practical examples. With that, we pass on to the next talk in this session, complications during endoscopic procedures, and that is post-ERCP bleeding, something which we are all afraid of. And we have Dr. Mahesh Goenka to elaborate on that. And he